Welcome to ModPath Chat, the official podcast of modern pathology, featuring interviews with authors and experts on the latest science, technology, and developments in the field of pathology. Your host, Dr. George Netto, is the editor-in-chief of Modern Pathology and the chair of pathology at the University of Alabama at Birmingham. Here's Dr. Netto.
Greetings, everyone. Our guest today is Dr. Brooke Howitt from Stanford University, and we're so honored to have you again, Brooke, here. In way of introduction, she's already an expert, a very well-known expert in GYN path with over 100 publications, and really an example of what a very successful translational anatomic pathology researcher path should pursue. Vested and versed in all kind of technologies. So clearly the old technology, H&E and immuno, but a lot of NGS, even moving into the domain of spatial and single cell omics, which is really should be our domain as topographers and visual experts. So with that in mind, clearly her focus is on GYN tumors and their precursors, and we're here to discuss her team's latest study in modern pathology on really exploring PTEN, any predictive value, any prognostic value in high-grade serous carcinoma. So welcome, Brooke, and thank you for coming again.
Thank you so much, Dr. Netto, for having me here. I'm really excited to discuss this paper and project. Excellent.
And credit to your team, too. We don't have time to mention everyone, but like everything, team science, and it's really the way to go. So I'm a bit surprised that's one thing, GU beat GYN. 10, 15 years ago, we were doing a lot of PTEN and mTOR and on prostate and bladder and kidney, obviously. So why now in high-grade serous?
Yeah, I guess, this has always been in the back of my mind. We've known about PTEN and endometrial cancer for a very long time. And back when I was training at Brigham, there was this very funny, finding in the mouse models where mouse models for high-grade serous carcinoma, they actually didn't generate high-grade serous carcinoma tumors with just P53 and BRCA in alterations in activation. But when you add PTEN, that generated these tumors from the fallopian tube that recapitulated high-grade serous carcinoma. And I always found that really interesting because we don't really think of PTEN as being a driver of high-grade serous carcinoma. And in fact, in the endometrium, we use PTEN as a marker to help distinguish serous carcinomas of the endometrium from endometrioid carcinomas of the endometrium. So it always was like kind of in the back of my head as this kind of unusual kind of biologic phenomenon that didn't really make sense. And then, as I was working on high-grade serous carcinoma projects, actually spatial transcriptomic projects, and have generated, these huge numbers of tissue microarrays and cohorts with clinical data, I thought, let's just explore this PTEN thing. And so that's kind of how the project started.
Awesome. Very well put. And of course, you added the other relevant markers, ER, PR, AR, and some immuno. Nowadays, everything we need to sprinkle a little immuno oncology markers, so FOXP3 and PDL1. And so tell us about the cohort. And so we already know it's TMA, you did immuno. What else did you do, and how big was your cohort?
Yeah, so the cohort included 76 patients, and the TMAs were actually constructed in a different way, I think, than maybe people think of as TMAs. We did almost every patient had both adnexal tumor sampling and omental tumor sampling, and in many cases, multiple different regions of the tumor were sampled, and then each region was sampled in duplicate. So one patient, although it's tissue microarray, may have 16 cores represented across the TMAs, and it's very carefully annotated. So it allows us to assess for heterogeneity across anatomic site and even regions within the same anatomic site in a way that is still cost effective to do large scale immunohistochemistry and other spatial transcriptomic type studies.
Excellent. I'm glad you delve into the detail of how you constructed a TMA, because a lot of time that is the Achilles heel of TMAs is sampling, and the traditional way we used to do 3-4 spots with benign, and especially with immune genomics and all that. The question is, well, are you covering all areas, the leading front edge of the tumor, and what have you? So that's something we can't discuss too long here, but it's important for our audience who are contemplating is to think about these factors. So that's wonderful. And clearly you did some target panels, some NGS, and can you explain a little bit about what 500 gene, how big was that panel?
I believe it was a mix of, some of them were our internal, the Stanford NGS panel, and some of them were the standard commercial lab panels that are around 400 or 500 genes. But again, they're targeted just exon sequencing, so that's certainly, in many ways, especially for PTEN, a limitation of this study in the context of the genomics and instability of high-grade serous carcinoma.
Excellent. So, and that will tie into the findings. So by IHC, you identify loss or sub-clonal or clonal that really didn't pan out on some NGS. I think that's where you were heading. So can you share with us the important findings here?
Yeah, so we found overall about 21% of our high-grade serous carcinomas had either complete loss or subclonal loss of PTEN by immunohistochemistry. But then when we looked at the molecular alterations, we couldn't really account for the vast majority of protein expression loss. Mm-hmm. And we also interrogated the CBio portal, publicly available data to look at mutation rates there. Their mutation rates were very similar to ours, around 4 or 5%. And in addition, we looked at methylation status, thinking maybe there was some epigenetic mechanism that results in loss of PTEN expression. And based on CBio portal TCGA data, that doesn't really seem to be the case. And so I think, we don't really know the answer, but presumably PTEN is a very large gene, and we know that high-grade serous carcinoma is characterized by extreme genomic instability and large-scale rearrangements. And it may be that targeted NGS and even exome sequencing is not sufficient to identify large-scale rearrangements that result in break in the PTEN gene. And additionally, it's so heterogeneous, and some of these subclonal, they may be too small of variant allele frequencies in the part that was sampled for sequencing, right? So the IHC may allow us to see things that we can't really visualize.
Here we go. Superiority for doing the good old paraffin with immuno. Excellent. And it works, right? It seems to predict. So tell me what it predicted and what it didn't.
Yeah, so we found, a few different associations. So one, we found an association with ER expression as far as other immunohistochemical markers. And then molecularly, we found that it was mutually exclusive with cyclin E amplification, which was also confirmed in the TCGA cohort. And then as far as clinical goes, we found that it not only predicted a worse progression-free survival and response to traditional platinum-based chemotherapy, but we also found a suggestion that it may predict non-response to PARP inhibition, which is really important for high-grade serous carcinoma, as PARP inhibitors are very frequently used either as maintenance or for relapse.
That's extremely important. So, and clearly, this study probably didn't look at that mTOR inhibitors because these were not, but that will be another thing to pursue, right?
Yeah, for sure.
And I'm not. I must admit, it doesn't come to my mind where other solid tumors where PTEN loss is predictive of non-response to PARP. And I know we discussed that before we started the podcast. Can you explain a little bit what you think is going on here? Because supposedly you mentioned cyclin E1 has some mutual exclusivity with BRCA, and how is this interplay between the three markers or lack of?
Yeah, so I think, the cyclin E amplification is only found in tumors that have intact PTEN. And the cyclin E amplification is also associated with chemotherapy resistance and PARP inhibitor resistance. And so I think that I'm not sure. I mean, it would take kind of better in vitro studies to kind of understand the reasons for these things. But it does seem that the PTEN-deficient high-grade serous carcinomas identifies a different subset of patients who might not respond to PARP inhibition, in addition to the cyclin E amplified patients. And so I think understanding better these different molecular subgroups of high-grade serous carcinoma to predict which patients may benefit and may not benefit from PARP inhibition is really critical, because now there are additional other options for patients to receive adjuvant or kind of different therapies, second-line therapies at relapse.
Fascinating. So, the other thing is you mentioned it correlates with ER. I just wanted to clarify that the group that lost PTEN was ER negative, tended to be.
That's right. That's the trend, right? Yeah.
And there was no association, because we mentioned FOX and PDL, so and CD8, it wasn't any correlation with TILs or PDL, correct?
No, correct. Yeah.
Wonderful. This is very exciting, and thank you for submitting it to Modern Path and sending us all the great studies. By the way, for those of you who are going to watch this podcast on the USCAP YouTube channel, you will see in her background all the future studies, all the blogs and the typical translational anatomic pathologist and all the sticky notes. So there'll be a lot of more studies, important studies that will impact our patients, and hopefully you send them to Modern Path. You're on the editorial board, so we're going to make sure you send us here first. So.
I usually do.
Thank you very much, Brooke. Congratulations to you and your team, and thanks again.
Thanks for having me.
Any opinions expressed in this podcast are the speaker's own and do not represent the views of Modern Pathology, Springer Nature, UAB, or USCAP. Your ModPath Chat host and scientific director is Dr. George Netto. Producers are Christina Crow, Amber Jackson, Dr. Sarah Jang, and Dr. Catherine Ketchum. Technical direction is provided by Kaminsky Productions, music by Mitch Neubauer. Thanks to the authors, reviewers, and editors of Modern Pathology for making this podcast possible.